And let me turn now to introduce the moderator for our next panel. Chris Kohler is also a member of the Workshop Planning Committee. He's president of the Milbank Memorial Fund, which is a 116-year operating foundation working to improve population health. And he also previously served as the Health Insurance Commissioner in Rhode Island, and had the distinction there of doing some really revolutionary work around primary care payment reform. So Chris, let me turn it to you.
Thank you very much, Mai. And Randy, if you could hang on for a little bit. I got some self-disclosure too, but we'll have you wait for a little bit. So this is our payment session. This is called Payment Models for Advancing Health Equity and Community Health. I want to draw a distinction that Mai made at the start of the previous one. It's very simple, but it works. Finances is dollars in, payment is dollars out. And so we're going to be talking about specifically ways to pay specific providers. We proceed with caution, pay specific providers in terms of, but to our goal of integrating services for whole person health. We proceed cautiously because of the admonition that Mandy Cohen gave us about over-medicalizing everything, but we acknowledge that, like Willie Sutton, healthcare is where the money is. We have to look for that place where we have to go where the money is. And the money is in the healthcare side. It's not, as Ben reminded us, in the health side. That said, Randy, and here's the part, the disclosure piece. I preceded you at Bread for the City by about 15 or 20 years, when as a fresh-faced college grad, I actually spent a year in volunteer service at what was then Bread for the City, which operated doing emergency food and clothing at 14th and N. They certainly did not have the capacity in Northwest. They certainly didn't have the capacity to do any of the services that Randy described, but they have built up the capacity to do that from the social services side as opposed to from the healthcare side. So they move into healthcare and health services from the perspective that's informed by their roots in social services. So I think that maybe presents a model for us as we think about the challenge of how we pay providers. That said, where I want to sort of, and if you could proceed to the next slide, please. Our challenge is going to be to talk about the payment and payment of specific providers. I think we've got a great panel that's set up here. I was really struck by Ben's insight from the VA. If there's one thing that he could try to export from the experiments that the VA has been able to put in place, it's to organize health services, this is not my phrase, around what matters to you, not what's the matter with you. And our challenge is, how do we get payment that reflects that? And that what matters to you is both you as an individual, and as we heard from Randy, you as a community. And how do we organize payment to reflect services that the patient values and that the community values? So with that, I want to introduce our speakers. We've got a great panel, as I said. Nathan Chomilo is the medical director for Minnesota Medicaid. Asaf Biton, who I've had the pleasure of working with on the NAM committee on implementing high quality primary care, is the president of Ariadne Labs. And Cara Odom Walker is the vice president and chief population health officer at Nemours. Nathan, you're going to start off with some of your experiences in Minnesota around taking up this challenge. How do we pay providers to promote the kind of care we've been talking about today? Thank you.
Thank you, Chris. So I'm happy to be here. As I said, Chris said, I'm the Medicaid medical director for the state of Minnesota. I've been serving in that capacity since January of last year. So it's been an interesting first 16 months. Next slide. So wanted to touch on three different aspects of our program that I think really get at how do you try to start paying for health equity. First is our integrated health partnership program. And so back in 2008, Minnesota passed legislation to aim to improve the affordability of healthcare, expand coverage, and improve health. And then mandated in 2010 that we test alternative healthcare delivery systems, including accountable care organizations. And so in 2013, we had our first 6 IHPs launched, covering about 100,000 of our beneficiaries. And the idea was to improve the health of our Medicaid and then Minnesota Care, which is our basic health program, enrollees by lowering cost of care through flexible arrangements between providers and the state, looking at value-based contracts with providers, looking at cost, quality, and health outcomes with incentives to improve delivery while maintaining flexibility to meet the needs of their community, and then really trying to focus on sustainable relationships and resources to meet the social determinants of health. And so the contracts last for about 3 years, allowing us to monitor the IHPs in regards to the low cost, high quality outcomes while focusing on those results. Next slide. So those who are involved include a wide spectrum of beneficiaries. So again, our medical assistants, or which is what we call Medicaid in Minnesota, and then Minnesota Care, both those covered by fee-for-service and managed care, as well as it being primary care centric. So really trying to build flexibility for those beneficiaries whose healthcare isn't necessarily managed by primary care providers, and looking at our system being responsible for defining what are the core set of healthcare services in identified population, and really trying to have that be led by the providers, and having them, encouraging them to engage with community to really define what are the potential needs. Looking at the total cost of care and shared risk. And so, the specific IHP's performance is measured against the total cost of care target derived from their historical performance, and then adjusted for changes in population risks and trends using retrospective claims and managed care organization encountered data that's available to us. And then looking at if they meet the robust quality metrics based on clinical utilization and health equity goals, that the potential, the savings is split between the IHP and the state. And so really DHS in our state agency acts as a facilitator partner, providing detailed data, analytics reports, and support to the IHPs, as well as helping set those goals. Next slide. And so this provides multiple opportunities for a wide variety of different provider participants, and really focusing on the social determinants of health and meaningful partnerships. And so after our initial launch in 2013, we're not yet advanced there. So if you can go back one. In our initial launch with 2013, in 2018 launched IHP 2.0, looking more really specifically on social determinants of health and community partnerships. And so looking at things like how to address food insecurity, for example, looking at things around the opioid crisis and metrics there based off of each community's potential needs. And to date, our state has 27 IHPs covering about 430,000 beneficiaries, with about half of them in the Twin Cities area, and then another half outside of the Twin Cities area, involving 500 different provider locations, more than 10,000 individual practitioners. Next slide. So in addition to our IHPs, we've stood up a housing stabilization benefit. And so back in 2012, we first explored Medicaid funding for housing services, but this was eventually dropped from what the state brought forward to CMS. And then in 2015, CMS issued the Housing Bulletin, coverage of housing-related activities and services for individuals with disabilities. And so Minnesota then planned and got in 2017 a legislative approval to begin working towards a Medicaid-funded housing stabilization benefit. And after discussions and tweaks with CMS, our agency determined that the 1915I Home and Community-Based Services State Plan Amendment was the best fit, and got approval for that in August of 2019, and then 11 months later was able to launch that. Next slide. So you can see here that it's a benefit that's eligible to help people with disabilities and seniors finding and keeping housing. And so again, part of the home and community-based services state plan amendment, a member is eligible for this benefit if they are, again, on our Medicaid specific plan, as well as 18 or older, has a documented disability or disabling condition, and being assessed to require assistance and experiencing housing instability. And once they meet these criteria, then they're able to have the social services supports to hopefully help keep them in housing or prevent them from going into housing instability to help fund those supports. Next slide. So as of May, there are over 5,000 people enrolled, which is double the projected estimate for the program. Over 262 providers enrolled to be eligible to receive payment through the Housing Stabilization Services benefit, with an average of 45 to 50 requests a day for these services through our eligibility request system. Next slide. So the last piece that we want to touch on was how we are working on embedding health equity and addressing structural racism explicitly in our Medicaid managed care RFPs and contracting. Because our real goal is to be quite clear that addressing structural racism and promoting anti-racism is essential to really addressing health equity. That you can't say you're working on health equity if you aren't also finding ways to address structural racism. And so how do you capture and measure that as part of any the expectations for managed care plans who are serving our enrollees? And how do we focus on how we pay and award contracts by having organizations really address these issues directly? And so asking, how are you specifically addressing structural racism? And indirectly, so talking about describing efforts to use feedback you get to then address structural racism as examples, as well as to tie into the previous conversation of how really having community co-created solutions and community investment is really key to addressing health equity, and how can we find that ways to capture that in our RFP or a request for proposal process, and then eventually make it into our contracting so that we are making the right decision, the easier decision for our managed care partners. Next slide. And so when we think about some of the issues or some of the barriers or opportunities with this work, as was mentioned before, is healthcare's goal to solve poverty? And then if so, how do you incent and measure this? And so when we look at our IHP program, for example, developing these health equity oriented interventions as part of participation in their program is one of the important first steps. And then how do you measure that? And using either traditional quantitative measures, looking at utilization metrics, or looking at a combination of process and scale and scope, and then the impact as far as is it just a patient or clinical impact, or is there also trying to capture patient feedback? So these are some of the questions that our IHP team continues to work through as we are moving from 2.0 to 3.0, and seeing a lot of opportunity to enhance it to not just serve to serve more children and new mothers in particular. And so that's one area where when we look at the care and the payment for pediatric care in particular, we're still working on how do we kind of have this model better and capture what pediatrics does as well. And then how do we continue to offer this to more and more beneficiaries? It isn't currently available to all of our beneficiaries in Minnesota Medicaid. Next slide. When it comes to some of the challenges and opportunity for the housing and stabilization services, thinking through some of the challenges just with the home and community-based rule requirements, and how we are able to get more providers enrolled to serve the needs that we're seeing. And so we're seeing a lot of kind of barriers with hiring requirements, some of just the process issues and times to start services has been an issue. some of the issues with it being new, and so first in the nation, and so that requires lots of tweaks that then have to go through either state or CMS approval, and that can hamper our progress as well. And so some of those issues we're continuing to work through. And then lastly, just looking how we drive overall healthcare, racial and health equity through Medicaid, managed care, and contracting. And so, what are the organizations we contract with doing to address their own structural racism, become more anti-racist? How are organizations we contract with ensuring that their subcontractors have the same commitment to anti-racism? So if they aren't the ones directly providing the service to our enrollees, they are contracting that out to someone else. It's important that that other organization that is directly working with our enrollees has the same commitments. And then how are they not only addressing health equity, but racial equity? And again, really just making sure that the financial incentives for managed care organizations are really aligned with our incentives, or sorry, with our efforts around health equity and institutional racism, so that we don't continue to see these gaps persist.
Thank you, Nathan. I think what we're going to do is move from presenter to presenter. But before we go to Asaf, I just want to, this is something we've been thinking about. And so I just want to test the logic that I think I heard you say. When thinking about payment for whole person health, if I understand the logic of Minnesota Medicaid, it's no whole person health without population health, no population health without health equity, no health equity without addressing systemic racism. Is that sort of the logic model through the whole thing? So if you're going to get the money right, you got to get the money right across that entire spectrum.
Yeah, and I would add like one last piece I think again dovetails well with the previous conversation, is that you can't address structural racism without involving community. And so, but yeah, I think that progression is spot on.
Got it. Thank you.